everyone, today we are talking about orofacial pain part neuropathic pain. So we define neuropathic pain as a pain caused by a lesion or disease of the somatosensory nervous system. The etiology include trauma, ischemic or metabolic disturbance or maybe infection. So where somatic pain depends on stimulus only, the neuropathic pain independent of stimulus intensity. It involves some sort of damage to those pain pathways. Neuropathic pain is divided into episodic paroxysmal pain disorders and continuous pain disorders. Paroxysmal means there are sudden spasmodic attacks, so pain may occur several times a day. Continuous pain disorders that frequently result from deafferentation after injury in the peripheral and central nervous system. Deafferentation means removal of a part of the neural pathway. It is partially or total loss of the afferent neural activity to a particular body region by removing a part of a neural pathway. So, the first example of episodic or paroxysmal pain disorder, trigeminal neuralgia. From its name, we can know trigeminal means cranial nerve number 5. Neuralgia, neura mean nerve, algia, pain. So it's pain of the nerve cranial number 5. It's also called tic doloro, and in fact it affects mostly post-menopausal women older than 50. Typically, the 6th decade of life is the most common women can affect, but it can occur at any age. So trigeminal neuralgia means this nerve pain, which it is cranial nerve number 5. Cranial nerve number 5 can supply three branches, V1, V2, V3, or V1 ophthalmic zone, V2 maxillary zone, V3 mandibular zone. Clinical feature of trigeminal neuralgia. So you touch one part of the face and instant this electrical sharp shooting episode pain. In other words, pain is brief. It can be a few seconds up to 1 or 2 minutes. Paroxysmal pain means occurs for short interval of time. Lancinating pain means piercing. Brief means the duration of pain is short. So it affects any or all of these branches, which is V1, V2, and V3. As we say, V1 is the zone over supraorbital ridge, V2 skin of the upper lip, upper teeth and gum, V3 lower jaw and lower teeth. Classification. International Headache Society classified TN into two types, classical, idiopathic, typical, the second one symptomatic. Idiopathic means the cause is unknown. With the symptomatic, they have the same clinical feature, but the only difference is symptomatic is associated with lesion. It could be vascular compression or any tumor. When we diagnose TN, we should take history clinical examination. So when patients come to you, you should ideally have MRI scanning or CT to sure it is symptomatic type or idiopathic. When MRI image is normal, it means it's a classical TN. So we give to the patient AED, which means anti-epilepsy drug. When the patient take anti-epilepsy drug, if the pain relief, we maintain this drug to the patient. And if the pain not relief, it means we re-diagnose the MRI again. And when the MRI image is not normal, it means it's symptomatic TN. And the patient should have surgical treatment. We can manage TN with medical management. During the early stage of a TN can be managed with medication. Anticonvulsants are the treatment of choice, and carbamazepine is a good choice. But as time goes on, the medication can lose their effectiveness, and we are go to surgical management. There are 3 ways. The first one is decompression or MVD. Microvascular decompression is the first treatment. It's a form of open surgery in which an opening called craniotomy is cut into the bone skull. This exposes the trigeminal nerve where it leaves the brainstem. During this procedure, we look for a blood vessel that may be compression or sitting on the nerve and causing pain. Then we separated the blood vessel and insert cushion between the blood and the nerve. Second treatment is percutaneous stereostatic radiofrequency rhizotomy, PCR. It is more minimal invasive treatment. When we place an electrode through the skin of the cheek where the nerve enters the skull. Our goal in this procedure is to control the damage to the portion of the nerve that is involved in distribution of the pain. Treatment is radiation. In radiation, we use high focused radiation beam to destroy some trigeminal nerve fiber that produce pain. So the goal of radiation is the damage of trigeminal nerve root to interrupt the pain signals and keep them from reaching the brain. And we have to type gamma knife head frame and no valleys face mask. In this procedure, the pain relief may not occur immediately, but rather gradually over time. Now we have some peripheral procedures, all have the goal of inducing nerve damage. First one, trigeminal nerve block, which provide only temporary relief. The second one, alcohol injection, but alcohol injection have many complications like tissue toxicity, inflammation, and fibrosis. Third one, peripheral neurotomy. This is a simple procedure. Involve evolution or severing of the terminal branches of the trigeminal nerve with or without obturation of the foramen. And it is low risk procedure and can all done on all terminal branches of 3 deviation of TN. The fourth one is cryotherapy of the peripheral branches, also called ice application. It can have provide the pain relief just for 6 months, and it's also low cost procedure. Disease is glossopharyngeal neuralgia. From its name, it's glossopharyngeal, the cranial nerve number 9. Neura is nerve allergia pain. So pain of nerve of 9th cranial nerve. A condition similar to the trigeminal neuralgia. It's characteristic by recurrent episode of severe lancinating pain in the tongue and the throat and ear. It's more common in men and it occurs after age of 40. Severe pain and area connected with 9th cranial nerve, back of the throat, tonsil, base of the nose and ear. Clinical feature of glossopharyngeal neuralgia shares many of features of TN. But the pain location is in the glossopharyngeal nerve, especially on the posterior tongue and lateral oropharynx. The pain will be from few seconds to few minutes and is less intense than that of TN, but it is still the pain paroxysmal and episodic in nature. And it trigger many activities including chewing, swelling, coughing, talking, and head movement that induce pain. And it is a rare disorder affecting approximately 0.5 to 1 person. Causes of GBN is irritation of 9th cranial nerve, and some sort the irritation have never found, but it is usually caused by a blood vessel compression or irritation the nerve. Other possible causes for glossopharyngeal neuralgia are growth or lesion at the base of the skull or tumor or infection of the throat. And when it is associated with some lesion or tumor, it's called symptomatic GBN. To treat GBN, the first line of treatment is medication. Anticonvulsants is the treatment of choice, like carbamazepine, phenytoin, baclofen, may relieve the neurologic pain for a long period of time. Atropine can be used to prevent the related cardiac manifestation in vagoglossopharyngeal neuralgia. When the medical treatment fails, then surgical options include: we have MVD, surgical section of the glossopharyngeal nerve and the upper 2 roots of the vagus nerve, radiofrequency nerve ablation, balloon, stereostatic radiosurgery. If the pain is secondary to another condition, management of the underlying lesion must be addressed. The typical means not normal odontotooth allergia pain. If it is tooth pain, also known as atypical facial pain or phantom tooth pain or neuropathic orofacial pain. It occurs secondary to deafferentation, removal part of the neural pathway as a result of endodontic therapy or extraction. We define deafferentation as total loss of the afferent neural activity to a particular body region by removing a part of the neural pathway. So pulpectomy will be an example as with tooth extraction, where we are removing the tooth and the nerve source. Any source of afferentation that the tooth was supplying is removing. The pathologic mechanism of phantom tooth pain seems to be dysfunction or short-circuiting of the nerve that carrying the sensation from the teeth and the jaw that is triggered by some type of dental procedure. Areas of the brain that process pain signals appear to undergo molecular and biochemical changes, and this results in sensation of the pain. So the causes of the atypical odontologia is unknown, and some clinicals refer to this pain as idiopathic, but it is more common in women than in men found, most often in the middle age to older age group. We can treatment the phantom tooth pain by anticonvulsants, antidepressants, and analgesic. Some surgical treatments include rhizotomy, and gamma knife may be indicated in non-responsive cases. Post-herpetic neuralgia, from its name, post mean after, herpetic mean herpes, neuralgia nerve pain. It is potential or sequela or side effect of herpes zoster infection. Herpes zoster infection, it is varicella zoster virus or VZV. It's not the same as herpes simplex virus. If the pain caused by shingles, which is the same of herpes zoster infection, continue after the bout of shingles is over, is known as PHN. It's estimated that about 1 in 5 patients with shingles will go on to have PHN. The clinical feature of PHN, clinically you can see it as a small vesicle cutaneous or scarring, usually affecting the forehead area, and lose the normal skin color. The pain is spontaneous, burning, and may be present are dull and aching, and may be lacinating evoked pain. The post-therapeutic neuralgia occurs immediately after the skin rash or after about 1 or 3 or 6 months. Treatment of PHN is acyclovir is the medication in acute phases. We can use anticonvulsants, antidepressants, and analgesic. In extreme cases, we can use surgical treatment like rhizotomy and gamma knife. Vascular pain. What is vascular pain? Is a pain that develops when there is interruption in blood flow to a tissue, organ, or nerve. Symptoms include lack of circulation, pain, or heaviness. It also may be numbness or weakness, a feeling in the affected area. Arthritis. The name answer is an inflammation of a temporal artery. It's also called cranial arthritis or giant cell arthritis. Why temporal? Because the head is over temporal region. So this artery supply blood to the head and the brain become inflamed or damaged. The superficial temporal artery is the most commonly affected site. It affects female more than males and usually above 50 years old. Clinical feature of temporal arthritis. The arthritis that involve are ophthalmic, temporal, and occipital artery. Ophthalmic artery involved can cause ischemic optic neuropathy, which can cause lose vision in one eye. Temporal artery can cause headache, and occipital artery can cause stroke. And other clinical features like loss of appetite, jaw pain, fever, shoulder pain, hip pain, and stiffness. The highly characteristic feature is jaw claudication, which is described as cramping pain of masseter and temporalis muscle that increase with usage, chewing or talking, but is relieved by rest. If the pain If the pain and the stiffness affecting the shoulder, upper arm, and pelvis are present in addition to the characteristic unilateral headache, a diagnosis of polymyalgia rheumatica should be considered. Polymyalgia rheumatica, poly mean many, myo is the muscle of the neck, shoulder, and back and hips. Algia pain, so it's pain of these muscles. Diagnosis. To diagnose temporal arthritis, we always order ESR all the time. It's actually useless test. Why? Is still there is something wrong, but we don't know what it is. In this specific case, ESR is very helpful. So, if the ESR is high, the eye will go blind and lose the vision in one or the both of eyes. And also, you can take biopsy of the temporal artery and require to show skip lesion of inflammatory tunica and media with giant cell. The treatment is by high dose of systemic corticosteroid therapy. The dose can be reduced as the ESR start to fall. Is a primary headache condition that describes as throbbing pain on one side of the head. Migraine isn't just a bad headache. It is neurological condition with intensive neurological symptoms. Migraine trigger can be by stress, hormone, and environment. It is the most prevalent illness in the world. And 75% of the migraine sufferers are women. The underlying causes of migraine are unknown, be related to a mixed environment and genetic factor. And the recurrent can be moderate or severe attacks of migraine. The attacks last between 24 and 72 hours. And the symptoms of a migraine. The most important one is pain on one side of the head. The patient have nausea and vomiting, numbness or tingling in the face, leg or arm. The patients who have migraine become sensitive to light, to touch, to smell and sound. There are 4 phases to a migraine. We have prodrome, the first phase, which occurs hours or days before the headache. The aura, which immediately precedes the headache. The pain phase, also known as a headache phase. The postdrome, the effect experienced following the end of the migraine attack. Treatment of migraine depends on the age of the patient, type of migraine, how often it occurs, level of severity, duration. The treatment of medication is triptans or maxillat, and also stress management, OTC pain medication like aspirin, ibuprofen, paracetamol. Self-care reminders. Hormone therapy if a migraine occurs in relation to the menstrual cycle. And here we finish our presentation. I hope you understand the neuropathic pain from all the sides. And thank you for your listening.